Thank you.
Thank you so much. Thank you. It's a really great pleasure to be here with all of you today, and I want to echo the thanks to Sandy for getting us all together. And I'm going to try to race through the clinical presentation. I'm focusing on classical and hypermobile types of Ehlers-Danlos syndrome, the clinical presentations thereof. And as you've heard, our focus initially was on the Beighton Score, on the joint hypermobility, this 9-point scale that we use to assess joint hypermobility. And there are many problems with this scale, but it's the one that we use. And we can discuss other things that we might do. One of the big problems is that it doesn't look at hypermobility in the neck or the shoulders or the hips, which are other joints that may significantly impact the patient's quality of life. And the skin features, as you've heard, the atrophic scarring and stretchy skin and skin fragility. Whoop. There we go. That's a very stretchy animal model. And you've also heard about Dr. Castori in this really excellent review that he did in ISRN Dermatology in 2012, really laying out a very, very good picture of EDS as a multisystem disorder. And he included quite a few phenotypic features up until, I'm going to use this arrow here if I can get it to go here, yeah. So these black ones are included in Dr. Castori's. I have added these 3 in the blue because he did not address those, and I think we need to think about them in addition as part of the clinical spectrum in Ehlers-Danlos syndrome. So I think it's very well established by now in the medical literature that pain is a feature of Ehlers-Danlos syndrome, and nothing makes me more infuriated when I hear from a patient that they've heard from somebody that, oh, Ehlers-Danlos syndrome has nothing to do with pain. Because we can argue about a lot of other things, but this is in the literature now. And the pain may be muscular, myofascial, it may be neuropathic in origin. Headache is a major, major feature. And abdominal pain, pelvic pain, complex regional pain syndrome. All of these sources of pain can significantly impact the quality of life for patients with Ehlers-Danlos syndrome. In our clinic, we use the brief pain inventory. I have patients complete this questionnaire when they first come and all subsequent visits. And as I speak here, I'm going to give you a little bit of data from the Harvey Institute. We have done a survey of 300 consecutive patients with hypermobile and classical types of Ehlers-Danlos syndrome. And on average, the average pain score for both types was 5. And the worst pain score for the hypermobile was 8 and 7 for the classical. This is not a statistically significant difference. Now, chronic fatigue is also a really major component of the presentation for many of our patients with Ehlers-Danlos syndrome. And as one of my patients said to me, this is not just I'm a little tired. This is profound, disabling exhaustion. And many of my patients have told me that the fatigue itself can actually be more disabling than the pain. They say, I can deal with the pain. I know how to cope with the pain. But the fatigue just takes me out. I cannot get out of bed. Sleep disturbance is a major contributor to the chronic fatigue, and other possible contributors include adrenal dysfunction, hypothyroidism. Question about mitochondrial contributions to fatigue have been raised, and this is an area that still requires quite a bit of investigation. Fatigue results in this phenomenon. This guy's T-shirt says, my joints go out more than I do. And unfortunately, a lot of the sleep physicians that I've interacted with are just not really tuned into the idea of looking at the sleep architecture, which I believe is really Dr. Posinki, Alan Posinki, has actually taught me about this. He's an internist in Washington, D.C. The sleep studies very commonly will show that there's no obstructive apnea because that's what people are looking for. But really what we need to be looking at is how much time are people spending in the very deep, restful stages of sleep and in REM. And depending on the source that you look at, this number may be up to 25%. These two should be between 45 and 50% of the time. And I had one patient who came last week who was spending 7% of her time in REM and 4.2% of her time here in stage 4. So if you're not getting that really good restorative sleep, you're never going to wake up feeling rested. And I always tell people there's a reason why people use sleep deprivation as a form of torture, because our bodies are not designed to function without good restorative sleep. So this is a very important component. And the consequences of sleep deprivation are profound in multiple different organ systems. Now, the gastrointestinal complications in Ehlers-Danlos syndrome are many, and they run all the way through from the top of the GI tract all the way to the bottom, including dysphagia, esophageal dysmotility, and esophageal spasm, gastroesophageal reflux, hiatal hernia, gastroparesis, bowel dysmotility, and rectal prolapse. And these complications can be very severe. I have one 22-year-old patient who literally, she does not move her bowels independently at all. And there have been multiple patients I've interacted with over the past several years who've required surgery, colon removal, because of their colons are not moving. So understanding the basis of the bowel dysmotility, the gastroparesis, this is a really very important thing. And it's part of the autonomic dysfunction, I believe. And if we can get at the roots of the autonomic dysfunction in Ehlers-Danlos syndrome, we may have a better understanding of some of these GI problems. And in our series of 300 patients, these are the percentages. Many, many patients presenting with nausea and abdominal pain. Constipation is extremely common, and bowel incontinence. I mean, 10% is a large percentage of people to be experiencing symptoms such as bowel incontinence. Now, headaches in Ehlers-Danlos syndrome also have multiple potential explanations and underlying factors. The headaches may be muscular, they may be myofascial, neurogenic, they may represent migraine or vascular headache. Temporomandibular joint dysfunction may be underlying, and we may have decreased intracranial pressure from CSF leaks or increased intracranial pressure from Chiari malformation or disruption of venous drainage secondary to a phenomenon called chronic cerebrosinus venous insufficiency. Now, this last phenomenon is something that I've just learned about in the last year. Is quite controversial, but seems to be a real thing. And this is another area where we need a tremendous amount of additional information, understanding what are the normal variants in the venous drainage from the head, and how can we further understand in which people these changes are really contributing to their headaches and to their dysfunction. Dr. Henderson's probably going to tell us more about increased intracranial pressure. But typically, the patients will tell you, it feels like my head is going to explode. They're very sensitive to changes in the barometric pressure. They may be sensitive to changes in altitude. Some people have told me, I just can't fly. Changes, I can't go up there. It's too painful. Can't go to Denver. Altitude changes are too problematic. And some women report increased symptoms around their menses when there's increased additional fluid on board. The increased intracranial pressure may be documented by increased pressure on lumbar puncture or with intracranial pressure monitoring. There are multiple potential causes, including Chiari malformation, disruption of CSF or venous blood flow. And often, these headaches are responsive to Diamox therapy, and we just have to be careful when we offer Diamox to be sure to monitor the bicarbonate levels and also potassium, because potassium can get low with Diamox as well. Pelvic dysfunction is an important feature. Women present with pelvic pain, uterine prolapse, bladder prolapse, and dysfunctional uterine bleeding and sexual dysfunction. Often these symptoms may be related, particularly the pain, may be related to myofascial trigger points in the pelvis, and myofascial trigger point release. Pelvic myofascial trigger point release may be very helpful for many of these women. Again, in our series, looking just at urinary symptoms, about 30 to 38% presented with urgency, 21 and 26% in the classical and hypermobile diagnoses presented with incontinence. 40% were presenting with urinary frequency, and 9 and 10% with recurrent urinary tract infections. Exocrine gland dysfunction. This is an area that really requires a tremendous amount of additional work as well. We see pituitary problems, thyroid problems, problems with the exocrine pancreas, adrenal insufficiency, and then gonadal dysfunction. And I think one of the main contributing factors to that may be a unifying feature may be the increased intracranial pressure, because if the pituitary is experiencing increased intracranial pressure and that very sensitive blood supply to the pituitary may be interrupted, that could result in a panoply of endocrine features. But this has not been well documented. The frequency of these various complaints in people with classical and hypermobile EDS is not well documented, so there's a lot of work that needs to be done in this particular area. Now, in terms of cardiovascular manifestations, mitral valve prolapse is common on echocardiogram, usually not a problem. Aortic root dilatation, similarly, we see aortic root dilatation, but it usually does not get enlarged to the point that the risk of dissection is high. And often we see it in younger children, and then they seem to sort of grow into their aortas, and it's not as much of a problem in adulthood. Venous insufficiency, this is a really, really interesting issue. You know, for many years I thought people had orthostatic intolerance because they pooled their blood in the veins in their legs, and the veins have connective tissue, and the valves are made of connective tissue, so gravity is pulling the blood down into the legs, and that all makes sense, but it doesn't explain this new phenomenon of cerebral sinus venous insufficiency. How can we explain the venous insufficiency coming from the head when gravity is working in our favor, getting blood to the heart from the head? So I don't know now if there's some fundamental biological or physiological anatomic difference in the veins that is a fundamental feature of Ehlers-Danlos syndrome. We have yet to work that out. And the tachycardia and orthostatic intolerance, these are parts of the autonomic dysfunction, as well as chest pain. People will say, yes, I have chest pain, it's part of my POTS. How do we explain that? I don't know. But here you see the frequency in our population of palpitation, syncope, dizziness, chest pain. These symptoms are very common. And these are, again, consecutive patients who are presenting to the Harvey Institute. Sorry. Now, Castori lists immune dysfunction as one of the elements of Ehlers-Danlos syndrome, and I'm coming around to the idea that there has to be some element of immune dysfunction as part of the phenotype. I think so too. Many of our patients complain of frequent infections. I've had several patients who've been diagnosed with common variable immunodeficiency and also with autoimmune disorders, including systemic lupus, rheumatoid arthritis, psoriasis, Behçet's disease, mixed connective tissue disorder. And then I think we can put mast cell activation disorder in there because really the mast cells are, with their excessive activation, that is a dysfunctional reaction. And this mast cell disease it doesn't occur in everybody, but there is a subset of patients who develop flushing, hives, anaphylaxis, profound reactions to both foods and medications, environmental stimuli. And many of these people respond very well to therapy for mast cell activation disorder. We give them H1 and H2 blockers and chromal and sodium. And something I learned recently, the herb quercetin, Quercetin, is a natural remedy that stabilizes mast cells. And many people do just as well with that as they do with the chromal and sodium, which is way more expensive. The mast cell disease may reflect increased stress levels and autonomic dysfunction. We don't know why our patients with Ehlers-Danlos syndrome are more susceptible to this particular phenomenon. You've heard a little bit about the hematologic complications. We know patients with Ehlers-Danlos syndrome have easy bruising. There are bleeding complications. There are many patients who've been told they have von Willebrand disease, but when you actually measure the von Willebrand factor, it's normal. So it's something else in that same pathway. Now, on the flip side, there are patients who have increased susceptibility to clotting. They seem to have a thrombophilia. And the cause for that, again, I really don't know. Some of those patients are on mega doses of Lovenox, for example, and still presenting with clots on treatment. And it's obviously very difficult to manage clinical situation and very puzzling physiologically to explain. And then we may also see iron deficiency as a result of malabsorption as another possible hematologic complication. Dr. Henderson is going to give you chapter and verse on the neurologic complications, which may include craniocervical instability, Chiari, syrinx, cervical instability, either at C1-2 or lower. We see degenerative disc disease in patients with Ehlers-Danlos syndrome at a very early age. In teenage years, if you do an MRI of people with classical or hypermobile Ehlers-Danlos syndrome, you will see discs that look like they belong in an 80-year-old. Dr. Henderson's going to talk about occult tethered cord, and we have the autonomic nervous system dysfunction, which affects many organs in the body and may present with postural orthostatic tachycardia syndrome, neurally mediated hypotension, sleep disturbances, the exocrine dysfunction, GI dysmotility, temperature instability. All of these are manifestations of autonomic dysfunction. Just to highlight here, the sleep disturbances are in 65 and 77% of our patients with classical and hypermobile EDS. So it's a very big, but headaches also a very common presenting symptom. And here you can see that 56 and 52% are presenting with numbness in one or more extremity. I'm just going to keep moving because we're running out of time. The psychiatric symptoms, Alan Pasinki does a wonderful job of talking about these as pseudo-psychiatric symptoms because really his belief, and I agree, that many of these are related to the autonomic dysfunction and the sympathetic-parasympathetic imbalance that many of these patients present with. We have to mention drug metabolism. Many EDS patients do not metabolize drugs as expected. They report that they're slow to respond to the cane derivatives in the dental office. They need multiple injections and they wear off very slowly. And there are many drugs that metabolism is either prolonged or accelerated I'm coming around to the idea that all EDS patients should have testing for pharmacogenetics. Because I think that may give us a clue. Number one, it helps us to determine the best way to treat them for many different things, and it also might help to give us a clue to some of the underlying genes that we don't yet know. So for sure, this syndrome can be disabling. And we look at the Karnofsky Performance Scale as a measure of how well people are able to function. And we ask them to fill out the sentence, or circle the sentence which best describes how they are functioning in the world. This is a 100-point scale, well, by tens, starting with I have fatal processes that are rapidly progressing and I am near death, to I feel normal, no complaints, no evidence of disease. And in our population, the mean Karnofsky score was 70, which people say I am able to care for myself, but unable to carry on normal activities. So that is a quick Cook's tour of Ehlers-Danlos syndrome clinical presentation. I look forward to further discussions with you all about it.
We have time for a question. Dr. Dan.
Dr. Francomano, I need you to clarify your comments about immune dysfunction. Are you saying that patients with Ehlers-Danlos may develop immunodeficiency like CID or autoimmune disease?
So I do believe that they are at increased risk of developing autoimmune disease. They're certainly not born with it. They develop it in early adult to mid-adult life. The common variable immune deficiency may be a feature from very early on in life, and that may be something that they present with very early, but I think it's often not recognized because people don't look for it.
Yes, I say that because I'm an immunologist, and in everything I've read, for example, about the common variable immune deficiency, I've never heard association of ES. I think this is a case-finding issue, or?
Well, I think we need more information about the. First of all, I think most of the immunologists who are looking at the patients with common variable immunodeficiency would have no reason to look at those patients' joints, right? So they're looking at the immune function and not thinking about, is there a connection with Ehlers-Danlos syndrome? And for decades, we've been looking at patients' joints and not thinking about their immune system, but blithely writing down, they're having a lot of infections as youngsters, but no one's ever made the connection. So I just think it's worth looking at, and I mean, I'd really be very interested in talking with you about if there's some screening tests we might do in some of those patients to see if we can establish whether there is a connection or not.
Very interesting talk. Would you mind to share some more information about, you talked about the thrombosis of clotting disorder in EDS patients. Because the patient with thrombosis, I would expect them to have symptomatic, like leg swelling or the chest pain or these things. Do you have any statistic about how many patients, or what is the percentage of patients with EDS having the VTE or venous thromboembolism?
Right. I don't have statistics on this. We just have, between Dr. Henderson and myself, I think we could point to probably 10 or 15 patients who've had really, do you think it's more?
Much more, yeah. I would say 25% have hypercoagulability.
Yes.
We've been finding lots of intracranial thromboses.
So these are not presenting with deep vein thrombosis, and they're not presenting with PE. We're seeing intracranial thromboses, venous thromboses in the brain.
You mean venous sinus, cerebral venous sinus thrombosis?
Yeah, venous sinus, yeah, not the circular bullet. You see a lot of intracranial thromboses on the venous side. And I'm not talking about massive superior sagittal sinus thrombosis.
Right.
We see small thrombosis. We see selected veins that thrombose, and which are not showing up on the endocrine. And at a much higher rate than we would in the normal population.
And how did you diagnose that? By MRI?
With a CT angiogram, venous phase.
Oh.
And some MRVs, right? MR venograms. And the thing that's really telling about those patients is you put them on anticoagulation and some of their symptoms get significantly better. You take them off the anticoagulation, the symptoms return. You put them back on anticoagulation, they get better again. So sort of meets Koch's postulates in a way, you know, of establishing that that really is a contributory factor.
It's very interesting because as you also discussed in other symptomatology, the patient tends to bruise easily because of the vascular fragility. So when you put the patient on anticoagulant in the setting of easy bleeding, would you have a concern about the over-treatment or tip the balance to another side?
It's a worry, I have to say. I mean, we don't know why those people are at increased risk of bleeding in the first place. There's so much we don't know about this. So this is why we need hematologists to join with us in a partnership to try to figure all of this out. What should we be testing? What should we be doing?
Actually, I'm going to move on now to Dr. Henderson. We'll have time after the talk to ask some more questions, and there's a good 3 hours more afternoon to
Actually, I think
continue these
he's
discussions.
doing some things with the camera where he wanted the next 5 or 10
Okay.
minutes. So if you want to keep the questions, it's a perfect opportunity.
Al, Dr. Burton, and
I get a little nervous when
We have families where there are multiple affected people who have all of these symptoms in various combinations, and you know it's inherited in what looks like an autosomal dominant fashion. I think there are definitely subtypes, as Dr. Mendoza mentioned, because there's some. I mean, we can, those of us who see a lot of these people can kind of put them in boxes and say, oh God, you guys look more like each other than you guys. And I think doing that kind of classification will indeed be helpful to us in the gene search and may eventually, hopefully, be helpful to us as we try to find more rational therapies for all of this. Dr. Henderson and I were saying at dinner tonight, it feels like we're missing something fundamental, that there's some piece of this puzzle that we just have not come to yet, you know. And that when we see it, we're going to say, of course, how could we have missed it for so long? But it is, I mean, these are the positive review of systems, you know, and you can almost make this diagnosis based on the positive review of systems.
final question. Final question, you got it.
Thank you very much. I'm Lisa Pagan, a pediatrician from London, Ontario. I'm sorry I was late, but I brought your representative to give us an overview. Do you think that there's any role of using low-dose aspirin?
So the question is there a role for the use of low-dose aspirin? You know, I think we need to know more about the thrombosis, you know, the state, because as we were saying, there is this bleeding tendency also. So I would like a hematology partner to tell me at what point should we be using low-dose aspirin, at what point should we be thinking about more aggressive anticoagulation. I think, I don't know, what's your feeling about that, Fraser?
If you look up the textbook, it'll say that patients with EDS have this bleeding tendency. Well, I've done about 1,000 EDS surgeries, and I've not had any abnormal bleeding in any of those 1,000 surgeries. And these are ASA4 grade, you know, very severe, high risk, well, considered high risk patients. But so I question that high bleeding tendency, unless of course they have type 4 vascular EDS, which is very rare, and I think I've only seen 1 or 2 in years of those. But we do see a lot of patients with brain fog, and and we postulate that there may be some kind of proclivity to, thrombosis, whether it's on the platelet level or the cascade level. Certainly many patients do have anti-cardioleptin antibodies, monoclonal antibodies, factor V. You see it's very common there. But we suspect that the presence of viruses or bacterial infections may be triggering some kind of microthrombosis that in the brain causes what Eric Singman at Hopkins calls sticky blood syndrome. And these microclots slow the blood flow through the brain, raise the intracranial pressure, and cause a tendency for intracranial hypertension, which we see raise spinal fluid pressure in many of these patients. So it's a unbelievably complex cascade of problems, and not really a single cascade, it's many cascades overlapping. And to try to tease these things apart is a challenge that we spend 18 hours a day worrying about.
Do you not think it's because of vascular fragility? Like if you have micro tears, small micro damage, that's a trigger for thrombosis. But at the same time, you have easy bruising, so you can see that kind of tendency as if they have a bleeding disorder, but it's not bleeding.
I think there is vascular.
Leaking some blood because of the micro damage.
Well, there is some vascular fragility, no question. But in terms of serious bleeding, I've not seen it.
No, I'm not saying serious, but the one you see by CT angiogram are micro thrombosis, right? Like a micro thrombosis.
Well, on the CT angiogram, we can't see the micro thrombosis. We're only postulating them.
Yeah.
But we do see we do see radiologically visible intracranial thrombosis. Yes.
Right. Yeah. But do you not think those teeny tiny ones are due to micro damages of vascular fragility? That's basically my question.
I mean, my personal opinion is no.
No? Okay.
So while Dr. Henderson gets his microphone on, and thank you, Dr. Francomano.